use the chat box. The chat box would probably be the preferred way. If you have a really burning question to ask orally, then that's okay, but we prefer to kind of save the questions till the end. Hopefully we'll address your question through the course of the presentation. We will make the slides available on both the TipQuick and the TI websites after the meeting. Give us a day or so to get those up on the websites. So with that, I want to just kind of touch base with you on what our meeting goals are for this morning. Of course, we want to just give everybody an update on where we are with the measures for both year 4 and 5. I'll touch base on the status of year 4 and just a quick couple of comments about year 5 performance measures and attribution method as well. Cameron Adams and the cheer team will be presenting on the year 5 details, and then we'll have some time for discussion at the end. So with that, let me touch base with everybody on year 4. And if we could go to the next slide, please, whoever is advancing the slides. Do we have the slides up? Okay, well, I'll get going while that's happening. So you should have received an email from me a couple of weeks ago concerning year 4 and the changed weights for the year 4 justice milestones. First, I'd like to say on behalf of the Access TI team and the ASU cheer team, I want to thank you for your engagement over the past months to assist with identifying and selecting the data sources and methods that would be most meaningful for the TI Justice Clinic performance measures. And we've had really great stakeholder input, and I know we've learned a lot that will serve us well as we work forward with Justice Involved Access members going forward. But despite everybody's best efforts, we were unable to implement the performance measure attribution method with sufficient time to implement the process for year 4. So we made the decision to evaluate the TI Justice Clinic year 4 performance solely on the QIC participation and the IPAT score submission. All the justice provider organizations have met the QIC participation requirement. So you'll want to make sure that you submit your IPAT scores when the year 4 attestation portal opens in the next few months. So as you can see from the slide, the milestone document has been updated to reflect the change. So if anybody has any questions about that, please feel free to contact me anytime, after the meeting or in the discussion period following the presentations. Just want to touch quickly on year 5. As I mentioned, Cam and the cheer team will be sharing details on the performance measure system that we'll be using for year 5. I just really want to encourage everybody to provide your input, your comments, questions, and as we explain the process, you'll see that the justice providers themselves, your organizations, will be submitting information that's really critical to the process working. So I want to thank you in advance for your support and commitment on that. And certainly if you have any questions or concerns, want you to let us know about that right away. So with that, I will turn the mic over to Cameron Adams. Cam?
Thanks, George. This is Cameron Adams, Data Coordinator for Targeted Investments here. And let me go ahead and move things along. There we go. All right, so just kind of wanted to recap, the progress that we've made here in creating a justice attribution process. Very innovative, very new stuff. Didn't have a lot of template to go off of. So we had some goals in mind, as we're creating this attribution methodology and determining, how to best measure a TIP justice organization's performance. So we listed a few goals here as we've considered, throughout the development of this process. We want this model to be aligned with tip justice population, mainly focusing on high-risk individuals, covering all members in tip justice zip codes. So I've mentioned before that TI is funded by special terms and conditions from CMS. We are focused on specific zip codes and member outcomes in those zip codes to maintain funding. So that is a factor here. Also want to look at something that, or want to identify a simple real-time attribution methodology in order to identify these members in a clear way that you can see that impact on the dashboard and performance measurement. It's inherent in the QIC and performance piece of it, and identifying best practices and changing practices to improve performance. I also want to make this transparent and fair and manageable for all stakeholders involved, and preserve the flexibility of our tip justice organizations. There's very diverse processes that have been adopted by each of you, and we appreciate that. And there's strengths in all of them. So we want to make sure that we're preserving that flexibility and moving us towards, best practices moving forward to best, these members here. So a few of the attribution methods that we've considered, we kind of started with only looking at the recently released members that were served by tip justice organizations, but we weren't real clear how those were going to impact the engagement-related performance measures, specifically the initiation and engagement of drug and alcohol abuse. So we did need to gather or identify members beyond just the members that are seen. So we kind of took the other end of the scope in our next approach here. We looked at all members that were released from incarceration that were living in tip justice organization affiliated zip codes. Everybody had a list of zip codes around their clinics that they were more or less affiliated with. But that identified a lot more members than those that were high risk, and required, it did not allow us to share those members, when we're determining the performance for tip justice organizations. If there was any question on which members were considered or which members they needed to reach out to in order to improve those measures, we weren't able to identify them because there technically wasn't a patient-provider relationship established. So we had to move on from that one and kind of create that relationship with primary care provider assignments. So we took that same list and said, okay, well, let's look at assigning those members to the primary, or assigning those members primary care physicians as physicians that work in the tip justice clinics. But that ended up being, again, too many members. It really intermingles high and low risk individuals, which is not constructive to our efforts here. And it was really too much to manage. So we said, okay, well, how can we identify the high-risk individuals from those and only, change the primary care assignment for those high-risk individuals? Good idea, except that, the criteria for that high-risk indicator, if you will, or sets of indicators, are spread out across different databases between access, the plans, determining if there's prior PCP engagement, and the TI justice organizations with their probation parole partners being able to provide some of the criminogenic risk information. So that kind of fragmented system, we weren't able to compile a good way of identifying high-risk individuals with those indicators. So we're kind of settling here on our last approach, which is the referral-based attribution. So instead of reinventing the wheel to identify members that are at high risk, we're relying on tip justice referrals to appropriately refer those members. This makes it so that there is an established patient-provider relationship so that we can share denominator lists. It does make it so that the tip justice organizations are aware of the individuals that we are holding them to for these performance measures, so that you can engage with them and increase performance. So, inherent in that is that we will need and do need referral lists in order to run these measures. So I do want to thank you for sending your historical reference list or referral lists to Access. It was helpful in determining the baseline that we're going to be calculating for year 5 here, and understanding some of the information that's been tracked in previous years. So moving forward, we will ask that all entities track tip justice referrals if you do make referrals to tip justice organizations, and that you will need to upload those prior month referrals. So the referrals made in the previous month to Cheer SFTP site in order to, or for them to run the measures and the dashboards here. So Access is reviewing the historical referrals and completing some necessary information so that we can, Cheer can run the measures for historic information. But for November and ongoing, we are asking the tip justice organizations and health plans, again, any entities tracking the tip justice referrals, to submit those directly to Cheer. So you can see that the first file here will be kind of an ad hoc file on October 15th. So that should reflect all of the referrals made between August 1st and September 30th. That'll close the gap for year 4 for the ones that you had previously sent to Access. And then after that, ongoing, we are hoping that you can send the referral list on the 15th of each month for the previous month's referrals. So the example there is on November 15th, the first file should include all the tip justice referrals in the month of October. So again, all these files need to be submitted through the Cheer SFTP. And you may be asking, what factors do we need to collect?
Cameron, this is Jen. Just a quick question. Is that something, and I apologize, I wasn't in the last meeting, but is that something that's been shared already, or will you be sending out the details of how we go about doing that and setting that up?
Yes. So the SFTP has been mainly set up with the tip justice organizations that have already worked on performance reconciliation with Cheer. So anybody else, any other tip justice organizations that have not done that, or any health plans that need to set that up, Cheer will be able to provide instructions to do so.
Okay, yeah, I need to review that with our internal team, as well as go through the review process of, I don't know that we have something set up currently, because I think everything is traditionally done through Access. So I just want to make sure if we have to have it go through legal review or other things, that 10/15 is a tight time frame, but I'll get on it today for sure.
Okay, good point, and we appreciate that.
This is
was there another question?
Yeah, this is George Jones with Arizona Complete Health. As far as referrals, how we set up the 3 clinics in the South was that regardless of the health plan, what we did was create relationships with probation and parole to send those referrals directly to, not through the health plan, but straight to the clinic. So the clinics, there's not a delay for that referral for that customer. So I'm thinking on those, it would be okay for us just to get the list from CHA, depending on what health plan, send those to the health plans, because those would be referrals from that health plan, whichever health plan they're from, because that's how we set it up. Does that make sense, or do you not agree with that?
Yeah, that makes sense. That makes sense. You know, even on this last historical review, if you will, you know, I received, you know, many lists from many plans and from the tip justice organizations, of course. So we do remove any duplicates out of that. You know, so if we see that Arizona Complete Health referred a member to CHA on their tracker, and we see on CHA that they received a referral from Arizona Complete Health or from any other entity that they were both tracking, you know, we would both see that that member was there and still only counts as the 1 referral to CHA.
Okay.
So, you know, one of the main things, though, is that, you know, Cheer does need some consistent elements in order to run the attribution methodology and calculate performance. So there's 6 items here that were more or less collected on the various files that I received that have already been being tracked. We do want to try and collect these moving forward. We really need to collect these moving forward into year 5. So the source here is just going to be, your organization, your plan's name, whoever's providing that referral list should be listed for all the members there, for all the referrals. The member's access ID, the member's release date, release from incarceration, referral start date, when they were referred to the TIP Justice Clinic, the referral source, so whomever it may be coming from, and their referred to organization. So that should be specific to a TIP Justice organization. So I know a lot of these elements are collected maybe in different formats already. If you want to add to that format so that it's a new field that's, collected in, the syntax that we, prescribe, or if it automatically reads off of what you're already collecting, that would be great. We don't want to hinder your current processes. I know those are things that have been built over time, but we do need to, have some kind of a consistent reporting in order to minimize errors and maximize the efficiency of loading those files into the attribution methodology, into the software. So with that, I will hand it off to Cheer to dive a little bit deeper into the details of the performance measurement.
Okay, thank you, Cam. I'm George Runger with Arizona State University Center for Health Information and Research, and we've been working with Access on the Justice Performance Evaluation methods. And so this is a little bit more details maybe to try and answer some of the questions that might come up. First of all, this page just shows the measures, so you've seen these before. To the right, we did list some of the NCQA HEDIS enrollment requirements associated with each measure, just to provide you a reference that, there are these enrollment requirements, particularly for things like the diabetes screening that requires approximately, except for some breaks, approximately 12 months of enrollment. And so these criteria could sometimes affect the denominators of the individuals, members that are being included in the measure performances. So we just thought we'd provide that. Next slide. As Cam mentioned, we would look at the justice population as the members released from a corporation over the last 24 months. And so released, say, for the year 4, that would entail October 1st, 2018 to September 30th, 2020. So that would define the population, and that would be used for determining kind of baseline performance for year 4. As George mentioned earlier, the metrics will just be used for measuring a baseline performance for year 4. And then we'll continue with that process going forward. So at the end of TI year 5, in September 30th, 2021, performance will be based on members released over the prior two-year period. Okay, this will define the populations. The measures will be based on the prior 12 months performance. Okay, so folks released, like 18 months ago, they may have a hospitalization in the most recent 12 months, and so they'll enter the denominator and the numerator of the measure if they do have the follow-up, for example. And also for interim reports that will show you in the forthcoming months, we'll use the previous 12 months or performance and the previous 24 months released from incarceration as the population. So we'll follow a consistent recipe, you might say, throughout the forthcoming year. So Stephanie, if we can go to the next one. The justice members, the attribution, as Cam mentioned, will be very simple. Justice members will be attributed to all the TI justice providers the member was referred to during the 24 months. We've looked at Cam looked at some preliminary data, and there are a few members that are referred to more than one provider, but the very vast majority, greater than 99% of them, are referred to as single provider in that time period, and that will be the attribution. So that provider will be responsible for the performance measures of that particular member. So the next slide. And as Cam mentioned, that was, that was selected after kind of an assessment of the advantages and disadvantages of different approaches to attribution. So that one's a very simple approach that I think matches the criterion that providers are aware of the population that they're being evaluated on. A few more details. We think of the population as being distinct in that the TI Justice provider's performance will be evaluated on Justice members only, not other access membership. We mentioned the attribution based on the referrals. We'll remove Justice members from the All Access PCP assignment file. So in other words, if you're also participating in TIP as a PCP organization, that the Justice members are going to be removed from your PCP performance evaluation. Okay, they're only going to appear in the Justice evaluation. Okay, and the implications of this down at the bottom are that, non-Justice members will not be considered or attributed for TI Justice Clinic performance. Okay, that the Justice clinics will only have the referred members in their denominator. And the Justice members' attribution is not affected by which providers they actually see. Okay, they're going to be removed from the PCP list, so it's going to be based on the referral process. Stephanie, maybe we can go to the next one. And so a few FAQs that we anticipated here. If a member refuses service from a Justice provider, will the member still be attributed? Well, the answer is yes. If they're referred, they're still considered attributed to that particular Justice organization. Okay. And again, if a non-Justice member is seen there by your Justice evaluated clinic, they're not counted in your measures. And then Justice members are not going to be counted in PCP, and I should also add BH, Behavioral Health Measure Evaluation, as part of the TIP program. Okay, and next slide then. Stephanie, oh, I guess we're set. So those the rest, we could skip these. I think these are just more of the enrollment details. So I think if we just go back to the, maybe there or somewhere, that was all we had for the formal slides. And so we're happy to address questions or comments of any type now for us or Access.
Yeah, George, this is Willa from Access. I'm just looking in the chat. Melissa is wondering, how is enrollment defined? Is it with Access or with the health plan or other? If you could just touch on that question in the chat.
Well, I would say that the enrollment is Access enrollment, because so we're dealing with the Access membership in the TIP program. So if they're in other lines of business with the health plan, then they would not be considered to be enrolled as far as the TIP program.
Hi, this is Melissa. That was my question. Would you mind going back to the slide so that I understand a little bit more? We deal with a parole population, and so they're coming out and they don't have access a lot of times. So they're starting their access when they get released.
Yes. No, understood. And that will, folks that, like if we're talking about September 30th, 2020, people that were released in much of this year would not meet the enrollment criteria for, say, diabetes screening. they may meet the enrollment criteria for things like follow-up after hospitalization, depending on how long they're enrolled, when the hospitalization occurred. And this is just standard sort of certified HEDIS criteria that we're following for this. So these aren't enrollment minimums that we defined. These are the measure criteria. And that's why we're looking back at a population over 24 months to make sure that we have enough membership that will meet the enrollment criteria. Other comments or questions for any of the folks here? Yes, when the access is suspended for jail time, how does that impact the enrollment? It can. There can be no more than one gap of up to 45 days. If you look at, for example, the criterion for the diabetes screening measure. Okay, and so, if there's more than one gap of more than 45 days, they're not going to be eligible for the denominator of the measure. And, it depends on when that gap occurs regarding the hospitalization measure, meeting the criterion. Well, this is to enter the denominator. So, in other words, they need to meet these enrollment criteria to even be considered for the measure. So if they don't meet these criteria, they won't enter the denominator, and so they also will not enter the numerator in either way, either positively or negatively. So they're just not, it's not considered that they're part of that performance measure population for that year if they don't meet those criteria. If they had a suspension for only a week, yes, for most of the measures, they would qualify. See, if you look at measure number 2, they must be enrolled on the episode end date, the day of discharge. So in some cases, if it's it's right at the discharge or something like that, there could be some edge cases, but in general, a week kind of thing would not exclude them for most of the measures. It's the lengthier stay that excludes them. If you look at the initiation of AOD, enrolled 60 days prior to the episode through 48 days following the episode. Otherwise, they will not enter the denominator. No, they would be. The question is, would the 60-day enrollment would not be impacted by a short suspension of access? I believe it would be. We can double check that with the HEDIS, but I think when they're saying in the HEDIS criteria, they have to be enrolled for continuous 60 days prior to the episode through 48 days afterwards. Otherwise, they would allow a gap. We'll double check that, but I believe they would not enter the denominator. It's there are details, and for this population, there's more opportunity for enrollment to be suspended. Yes, we could work through scenarios, and in fact, we do have a few slides on scenarios that we could put up on the website. So we could add some scenario slides. That, yeah, this is one of them, for example. that tries to show the enrollment periods for the initiation. Yeah, so it's basically showing the 108 days, 60 days before, and 48 days after enrollment requirement. And you can see that the little red line at the end there is indicating that someone who was released in the last 48 days before, say, the September 30th performance evaluation, while they cannot have been enrolled for 48 days after an event. So they would, folks just recently released like that at the end of the measurement period would not qualify for the denominator of the measure. If they're released during the blue time frame, or if they're, in that blue time frame is when the initiation events would be evaluated for performance, and they need to have that in the yellow, the 100-day enrollment period, right? The population that we're looking at would be everyone from the previous 24 months indicated by the gray line. So it is a little confusing to first look at it, but once you think about it a little bit, you realize that this is sort of a, kind of the standard approach for something like this. And the measures are just using the HEDIS guideline standards. So these are the kind of diagrams that we look at to keep it clear in our minds. So hopefully they're helpful. But we're happy to go through some of them with you as well. If you just send us, any of us as part of the TIP program, we'll be happy to set up a meeting and go through it with you. Yeah, I agree. The comment is it's the suspension due to jail that makes it confusing. Yes. Yeah, and we've scratched our head going through this.
So Dr. Unger, if I may ask a question here, just using this diagram as an example. So if a member was incarcerated, we'll say right here for a week. So it's before their hospital discharge, but within that enrollment requirement. Would this member be considered for this measure?
My understanding, that was something we're going to double check, but my understanding is HEDIS excludes them. And I don't know if Neil can comment further on that, but I believe they have to have that continuous 60-day enrollment for the HEDIS measure to put them in the denominator for that event.
Yeah, this is Neil Robbins with the team at CHEER. I did review the enrollment criteria for the initiation engagement and treatment, and it does require 60 days prior to the hospital discharge with no gaps allowed.
Yeah. Okay. Thanks, Neil.
Yeah.
Yeah. So the answer, Cam, is yeah, they would not enter, that event would not enter the denominator.
Thank you both.
The questions about the initiation of treatment. get them into treatment. Hospital one is more clear. Okay, so there's comments about the initiation of treatment.
Yeah, Lisa, I think if I'm understanding Dr. Unger here, it's really in relation to the hospitalization event tied to this measure. So maybe Dr. Unger or Neil, can you speak a little bit more to the denominator qualifying event for this measure, the hospitalization discharge?
Yeah, Neil, do you want to go through that?
Are we speaking about the initiation engagement of AOD treatment?
Yeah.
Right. So the initiating event, as I understand it, is an alcohol or drug abuse or dependence diagnosis. And that can be made in an inpatient setting or also an outpatient setting, but that's what initiates the event. And then, they have a certain period of time after that event initiates when they need to initiate and then engage treatment. The software, as part of the denominator exclusion criteria, it looks 60 days prior to that event to see if there were any other alcohol or drug abuse or dependence events. And it's expecting that window be clear of any abuse events. So if that window has an abuse event, then that member is excluded. But in order to do that check, the member needs to be enrolled for that entire period of time. If there's a gap in enrollment, then the software says, I can't check this window, so I'm just going to exclude that member outright. So if a member has a break in their enrollment due to incarceration, then that member will be excluded. Is that clear?
This is George. The only concern I have is we have a population that's moderate, high risk, and this might dwindle your sample pool down to absolutely extremely small, because if they're on probation, for example, they're on a suspended sentence, and they can just do a day in jail, or someone could get sentenced to weekends in jail as part of their conditions of probation. You know what I mean? So that's the only concern I have with it, is it really could. I'm not sure what type of sample pool you're wanting to kind of measure this, because it might highly affect it.
Cam, how long do they need to be incarcerated before the access enrollment ends?
I understand it's at least 3 days.
Okay,
before that's suspended.
Okay. So from that point of view, they would, even if they were, incarcerated for the weekend kind of thing, the enrollment would still continue. So we would be okay in that case. If we're talking more than that, then yes.
This is Paula Kressel with Mercy Care, and that's not what I've been seeing, and maybe I'm wrong, but I believe they're suspending within 24 to 48 hours. Maybe others are seeing different things, but that's what I see.
Okay.
I've seen the same thing on our end too.
All right.
Okay.
I guess this is Vicki. I'm trying to wrap my head around what our goals of this program are and how this supports the goals of the program. My understanding was our goals were to rapidly get people involved in treatment as quickly as possible and in services, so that we can help them with their reentry and prevent relapse. And I feel as if these time frames are actually excluding those people if we rapidly get them into treatment prior to the enrollment time frame, or if we're not responding, if we respond very quickly to relapse, then again, they're not getting credit for that, or if we respond quickly after somebody gets released, after being in prison or in jail again. Then again, they get excluded. So it's almost like we're excluding the population that we were trying to reach.
Understand the comment. You're saying that enrollment criteria is maybe too restrictive for this population.
Yes, and I think then we actually are excluding kind of what our very goals are of rapidly getting them into treatment quickly.
Yeah, I think the measures are looking for these qualifying events, basically looking at it as, a new episode in a sense. The measures actually say in the written description, they talk about a new episode of alcohol or drug abuse. And so I think that's the way they're thinking of it. But understand your comment about trying to work with this population to get them care as soon as they're released.
I think
This
that
is just. Go ahead, George.
I'm sorry. It's just a question of what we're calling a new episode, because that's part of recovery. Is we have people who will have bigger spans of sobriety, or it's not fail necessarily. It's we're working with a high risk population, and what do you define as new episode necessarily? Because we do have people that use while on parole and probation, and we keep working with them. They might be detained for a few days, but you know what I mean. It's sometimes it's finding the right course of treatment. Sometimes it's them understanding themselves more, but that's all part of the treatment process. I didn't know what we're really calling a new episode.
Yeah. Neil, were you just saying that the new episode was defined as outside of 60 days? Is that what the measure currently computes?
That's a good question, and I'll need to review the documentation a little more closely. For comparison, something like the follow-up after hospitalization measure, if the member has repeated hospitalization events that are pretty close together, then those tend to be rolled up into a single treatment episode. The same may be true for the initiation engagement of treatment measure, but that's something that I'll have to review.
All right, so it sounds like that review is one question. The general comment is things like the initial treatment right after release, which
I think it's a combination of both. It's the initial aspect. When we first engage, we're not going to wait for them to have been enrolled for long periods of time. We're going to engage and get them in treatment. That was the whole purpose of the targeted investment from, initially.
Right.
And then, again, rapidly addressing relapse or reincarceration and getting those services back in place quickly and rapidly so that we can get the person back on track with their recovery goals.
This is Paula with Mercy Care. The way I'm reading this is that it says the person must be enrolled for 60 days prior to episode end date. So it sounds like it's saying, not saying you have to wait 60 days to engage the person. Rather, they would only be counted if they had been in an episode that lasted 60 days, at least 60 days. That's kind of what it says, no? And then remained enrolled 48 days following the end of that episode, which
yeah,
I don't know how you mark that.
I think the intent there is, as Neil was saying, is if there's multiple encounters within a time period. So then the measures roll them into one encounter, and they need to associate a date with multiple encounters. And so they usually take the end date and they roll them together and they call it the episode. So if there's only sort of one encounter related to AOD, then it is the date of the encounter. Okay, now the release from incarceration is a little bit different type of event because, as we're saying, is most of these folks will not meet the prior enrollment criteria. Well, none of them will meet the prior enrollment criteria unless it was a very short incarceration.
But I'm saying maybe they would because that says prior to episode end date, not beginning date. So what they're saying there is that the person has been enrolled and had an episode of care that together are 60 days or more. So if the person's released and they start treatment the very next day, and then that episode of care lasts for 60 days, then they would be counted.
I see what you're saying. We can check on that. That's not the way things like the hospitalization works. But we can check on that in more detail. I think these issues are important that are raised, and I guess George and Kim and Willa, something we would discuss further.
I wonder if it would be helpful to take some real examples, real scenarios, and kind of walk them through the time frames to say, what would this really look like? So if we gave some examples of situations, and then we could kind of back it into the measures to see what would happen.
Yeah. This one right here shows, this one shows though that there is sort of a concern because, if there's if you do the initiation of treatment right at the release, very few of the members will meet the 60 days enrollment criterion. And we'll check at the end of the episode, but I think it's going to be difficult to get them to meet the current HEDIS criteria for this. Like this diagram shows for follow-up after hospitalization, for example. Oh, yeah, this is initiation. Yeah.
Yeah, if I may maybe add to the example here. So, if we have a member that is released from incarceration, we'll say here, we'll say that's January 2020. If a TIP Justice Clinic engages that member for initiation of treatment here immediately after release, then that member was referred to a TIP Justice Clinic. That member has released from incarceration in the past 2 years, so they're considered an eligible member for this measure. So if this member relapses here, they've satisfied this enrollment criteria. They've satisfied the enrollment criteria after. So the numerator qualifying event will be determined if that TIP Justice organization follows up with that member to initiate treatment again after this discharge.
Yeah, that's correct.
Cameron, this is Justin with Arizona Complete Health. Can you provide that same example, except rather than being a hospital discharge, it's a detainment for, say, a week?
So I think that's the part that Cheer is going to be looking into to see how that suspension plays into this 108-day window here. Definitely need to consult the records on that. I will confirm with Access. I actually just did last week on the suspension timeframe needing to be 3 days. There was a reason for it. I can't think of it right at the moment. And I see he had dropped off the call. So I will follow up with you on that. But if that's, it sounds like our preliminary findings are that if that member's enrollment is suspended during this window here, then that event would not count.
So this is Justin again. I guess just kind of processing and there's a limited time left for the meeting. I understand that, but if that person, same scenario, they had their 60 days or even 188 days of treatment for whatever initiated that treatment episode of care, and then they had an incident that put them in detention for any number of days that allowed for a suspension. Would that person be included or not?
So if that suspension happened within this window, I understand that it. Dr. Unger?
Yeah, that's correct. If the suspension happened within the window, they would not be included.
So if they had 108 days or 60 days prior to detainment of treatment for an episode of care for substance abuse, what have you, and then they hit detention, which led to a suspension, that would automatically exclude that individual?
If the access enrollment under the current measure format, with the access enrollment is suspended, yes.
So I can understand the kind of, I guess, the thought process, at least in my point of view, for relying on the HEDIS, the measures, but I'd have to imagine when the HEDIS measures were created, they didn't account for what it is that the TIP clinics are trying to do. So I do agree that it'll end up excluding quite a large portion potentially of the population. I'm wondering if when data analysis is done, if there is going to be a kind of a run through, that it can be done in two ways, where it's done strict to the HEDIS measures and then maybe interchanging a hospital discharge with, say, a jail stint, and what that data would look like.
That's worthwhile. That's worthwhile. I think that's something where we could make some preliminary analysis and look at the impact. So that's something that we could take as an item from this meeting.
So this is Paula with Mercy Care. Just to clarify, from the health plan's perspective, you're asking for those data points to be submitted on a monthly basis, and that would be at the point, because there's a couple of things in there that could be at different times. The release date and the referral date. So I'm thinking I would provide to you anyone who released in September, in that was referred to TIP in that October report. Even if, say, for instance, somebody releases very early in the month and I made the referral the previous month, I'm going to send you the data for everyone releasing during the month or the previous month, correct?
Yeah, yes.
Okay, and then not in the interest of time and not to not because I don't think the discussion about the measures not important. There's clearly some things to be worked out there, but that's not the analysis of that data down the road is going to be done by Access in terms of, looking at the data based on those rules.
Well, that's what the Cheer Center is doing. So we're currently doing that for the other areas of concentration in the TIP program, like BH and PCP.
Okay, thank you.
This is George. As far as release date, how important is that? Because with COVID and other things, there's a lot more people being incarcerated for maybe a day or two and then put on pretrial release, might go through 2 or 3 months of a disposition process. They are moderate or high risk. You know, they're still using in the community and they get on probation. Would them not having a release date of a recent release date exclude them, or how would that work?
Well, you know, for the release date, that's being used to identify the justice population. And so, you know, we're trying to capture a reasonable time period of members, and that's where the 24 months came from. And so, you know, on the edges of a few days, you know, within the 24-month period, we may omit or add some additional people, but in general, I don't think like a few days here or there on the release date would have a big effect.
So we have 24 months, as long as they've been incarcerated in the last 2 years, we're okay as that on a release date, is what you're saying? I didn't understand. I didn't get that part.
No, what we're saying is if they're released within the last 2 years, then they will be members of this population for evaluating performance.
Okay. Well, they'll qualify there, so that's not a problem. Thank you.
Yeah, yeah. We only have a few minutes left. We do have from, at least from the cheer side, a few takeaways from this to provide even greater detail into some of these measures, to take a look at the effects of the enrollment, the impacts that would have on some of these measures, because many of you have indicated that you think it will drastically reduce the population. And so that's at least from our side some takeaways. And then maybe in the last couple of minutes, I'll turn it back over to the Access group for their wrap up. But thanks a lot. Thanks for all the good feedback. It was really worthwhile hearing the comments.
And thank you, Dr. Unger. We do appreciate you, speaking to many of these measures here and many of the questions and presenting. We do plan to, use this attribution methodology, this performance measure methodology to calculate baselines here soon. So we will be able to, look at some more use case scenarios and how this referral list plays into those denominators and the performance measurement. So we'll be seeing, or confirming or, otherwise evaluating these concerns here, with actual data, here in the next month or so. So, we will keep everybody updated. And again, we will post these slides and this presentation to both the TI and the TIP Quick website, and keep everybody posted as we continue. George, any last thoughts?
Yeah, and I just want to echo what Cam said. Appreciate the cheer team and really appreciate everybody's input today, the meeting. That really, as I said at the outset, that really was one of the primary goals for having today's meeting, was to get your input and questions. And they've been, as usual, very informed and helpful. And at the end of the day, to Vicky's point, we do want to make sure that we can align what we do with the measures as closely as we can with the goals of the program. So we'll continue to work with you, and it sounds like through some forum, either another call like this or through other means, we'll be communicating back with you about the questions and the issues that were raised today. So again, thank you everybody for your time and participation.
George, is there any next steps for us as far as what you want us to do in the meantime?
Not at this point. I would, I guess, and I would throw this open to Cam, but take a look at that that referral information that we laid out on that slide. I'm not sure which slide that is. Take a look at that. Make sure you don't have any questions or issues with any of that information. Again, as we talked about, that will be one of the, one of the pieces of input that we'll need from everybody, from the plans and the providers, to make the whole process work.
Thank you.
Anything else before we wrap up? Okay, well, everybody, I hope you have a great day. And again, thanks for your participation.
Thank you.